Welcome to part 2 of chapter 2. So we're going to get into more physics here. Please go in and look at your folders. There is a worksheet that's part of this whole thing. The worksheet will be turned in or emailed to me for a grade. So that'll help you go through these calculations. Make sure you're ready to go for those calculations. Exam 2 will have calculations on it for compliance, resistance, so on and so forth. So be ready for those, and that's what we'll go over here. This will be more the applied stuff and stuff that we'll actually see with mechanical ventilation. So one of the things that we'll be looking at here is the characteristics of the conducting zone. The conducting zone, remember, is the airways that lead up to the site of gas exchange, and that's your gas moving in and moving out. So I'll make a lot of analogies to straws or hoses. So next time you see a straw or hose, or if you want to participate in some at-home fun with these lectures, then please feel free to do so. Get some application in there. And then we'll look at some characteristics of the conducting zone when we look at compliance. And compliance, remember, is how easy it is for the lungs to expand, right? How easy it is for them to stretch. And then we'll even talk about breathing patterns, or normal versus abnormal breathing patterns, and what that means. So characteristics of the conducting zone, we're pretty much going to be looking at Poiseuille's law and airway resistance. So Poiseuille's law is looking at a lot of different factors. So this is the movement of gas into and out of the lungs. So let's just do a quick example here. Here I have a large hose, like a fire hydrant, a fire hose, right? And then over here I have a small garden hose, right? If I were to hook these up to fill up a bucket, right? And I want to fill this bucket up with water. Which one's going to fill up this bucket better and more effectively and faster, right? The large garden hose will definitely do that. So when we're looking at Poiseuille's law, we're looking at how easy it is for a fluid to move and to fill it up, right? How easy it is for it to move. When we're looking at something like bronchospasm that decreases our radius of our tube, like a small garden hose, it's going to make it harder for fluids to move, and it's going to take a lot longer to fill up that bucket, right? So this is going to be what we call airway resistance, or what happens during like asthma or swelling of the airways. So when we're looking at Poiseuille's law, this is going to be a big one, and this even affects how we are therapeutic with patients. Bigger airways, so your trachea, mainstem bronchi, all those big guys change, right, length and diameter during inhalation and exhalation, right? They get smaller on exhalation, they get larger on inhalation. So the trachea, the bronchi, they all will move a little bit. Now they have cartilage in them, right? Those guys have cartilage in them, but they'll move with breathing, with ventilation patterns still, even though they have that scaffolding of the cartilage. And so that will affect airway resistance as well as Poiseuille's law when we're getting into this. So changes impact both the pressure, I'll just put the letter P there, and the flow. So flow is a V with a dot over it. So if you see a V with a dot over it, that means flow rate. Doesn't mean volume, it means flow rate. So both pressure and the flow of gas into and out of the lungs. This is going to be a big problem with some of our patients, especially patients that have chronic obstructive pulmonary disease. It's that flow of gas, the movement of gas usually is decreased because their airways are obstructed, right? There's something blocking the flow of gas into or out of their lungs. So especially with emphysema, right? When we look at emphysema, it destroys a lot of the cartilage and it makes their airways very floppy. So when they're exhaling, the airways actually prematurely close and it traps gas deep into their lungs and causes hyperinflation, right? So we have a big problem here because their flow of gas is reduced. And same thing with asthma, right? Their flow of gas is reduced, and they also during an asthmatic episode can have air trapping, just like an emphysema patient. So people with swollen airways, all these things can cause a really bad flow issue, and therefore we need to work this to help reduce the work of breathing that patient is doing. So Poiseuille's law, and I don't want you memorizing this, but I'll talk about it real quick. This is the old way. This is the official physics way of looking at Poiseuille's law. But some of the things that factor into Poiseuille's law is the radius of the tube. This is going to be the big one. We'll talk about this one in our situation, especially our radius to the fourth power, which will be a 16-fold change, either increasing or decreasing. All right, the radius of the tube. So if we have a small garden hose versus a large fire hose, right? The radius of the tube, right? The bigger the tube, the easier the gas to flow through it, right? The smaller the tube, the less the gas to flow through it. So Poiseuille's law looks at how easy it is for fluid dynamics, how easy it is for gas to flow through a bigger radius than a smaller radius. And this is going to be an exponential component. The viscosity of the gas is also something that we can affect as well when we're looking at the respiratory therapy. We can actually use a mix of helium and oxygen. So we can give someone 80% helium and 20% oxygen. It would be 80-20 mix. And what happens there is if their airways get small, we go from a fire hydrant to a small hose, right? So we got a smaller airway with an asthmatic. What happens to fluid dynamics? Does it get more laminar or more turbulent? Right? It gets more chaotic. It gets more turbulent. Right? It's going to be a lot harder for gas to move through there. Well, is there something we can do that reduces turbulence? Yes, we can make the gas less viscous, right? We could change the viscosity of the gas and therefore increase the laminar flow rate through that area. So we can decrease the bouncing and chaotic movement just a little bit, enough to where it needs a lot less pressure to get through that area, and it'll be a lot easier to flow gas into and out of the lungs. So therefore the lungs won't have to, their respiratory muscles won't have to work as hard to breathe, right? So we actually can affect the viscosity of the gas in some of our patients too, right? Just like with our croup babies, right? We talked about croup having that narrowing restriction of their upper airway right under their vocal cords. If we have that narrowing, we could reduce the work of breathing. We could reduce how hard they have to breathe by just giving them a mixture of helium with what they're already breathing, and that can actually help change the physics of the gas. We can change it from being chaotic to more laminar, and therefore help them breathe a little bit easier until we get that swelling under control. The length of the tube is also something we could change, especially when we go from an endotracheal tube to a tracheostomy tube. That's changing the tube diameter. We go from a very long tube to a much shorter tube, and in fact, a lot of times that's where we put a trach in a vented patient. From an endotracheal tube to a trach patient, we'll actually draw on arterial blood gas to sort of see if we need to change the vent settings, because we've decreased a lot of dead space. We've changed the length of the tube, and therefore it can actually change how the patient ventilates. So the length of the tube does matter, right? And even neonates will trim the endotracheal tubes to help decrease the resistance to breathing, right? It's pretty interesting. Change in pressure, we'll talk about this one a lot. We can do this too. We can increase the amount of pressure someone has on the breathing machine. So if we do have someone that has a severe asthmatic reaction, they go from a large tube to a small tube, like a radius, right? They go from a large fire hose to a small garden hose. We can increase the amount of pressure the machine uses to give them that breath, because we know that they're getting a much smaller breath if we don't compensate by giving them more pressure. And we'll get into that in a second here. And then the other factor is flow. So how easy, or the amount per time of gas, right? And so let's talk about that here. So Poiseuille's law in a new way is looking at simple proportions, and this is the equation that I'll be expecting you guys to manipulate when you're looking at this. We can either set it up for pressure to remain constant or for flow to remain constant, okay? So when we set it up for, and that looks like a V but should have a dot over it. There we go. Pretend that's a dot over the V, right? That represents flow. This is where pressure is constant, right? So if I want to look at the flow of gas and pressure is constant, if my radius changes, then my flow of gas changes, right? So let's say you have a milkshake. So over here, you have a milkshake. Over here, you have a milkshake. And you can do this at home. If you want to participate in a delicious at-home experiment, go make a smoothie or a milkshake. And you play along, right? Get a big straw. Get a really small coffee straw if you have one, right? Really, really small straw. Or just pinch off the straw if you want to use the same size straw. So if you're trying to drink this thick drink, right? This thick, viscous drink, what's going to be easier to drink out of? The one with the straw wide open, or large straw, or the one with the pinched off or smaller straw? Which one's going to be easier to drink out of, right? You're going to have to see that when you're doing this, trying to use the same pressure, try to use the same suction mouth pressure on both of these, you're going to have a lot less of the milkshake go into your mouth if you use the smaller straw, right? And that's what you're looking at here, right? If we have someone's lungs that start to close up, it's going to mean that we're not going to be able to get as much gas into or out of their lungs, which means their ability to exchange gas is significantly reduced, right? So that's setting it up for flow. So we could also set it up for pressure. So if we want 16 milliliters per second, right? That's our flow. It's volume over time. So 16 milliliters per second. So if I want 16 milliliters per second, that's what satisfies my taste buds. And I'm up here to this analogy again, right? I have my milkshake, one with the smaller straw, one with the larger straw, right? If I want that same amount of milkshake, that 60 milliliters per second, if I go from a bigger straw over here on the left to a smaller straw over here on the right, I'm going to have to increase, if I go from bigger to smaller, the pressure I need to get that same flow rate. To get that same amount, that 60 milliliters per second, I'm going to have to use a lot more suction pressure to get that same 16 milliliters per second. So this means when someone has a bronchospasm and the airways have a smaller radius, that we're going to have an increase in the amount of pressure it takes to get gas into and or out of their lungs, which means they're going to have to work hard to breathe, or we'll have to make the machine work hard to breathe to compensate. It's pretty significant. All right, so let's look at having this arranged for flow. So this is just looking at the flow rate. Flow equals the change of pressure times the radius to the fourth. So notice that the radius to the fourth is an exponential relationship. In other words, this whole thing, when we're coming down to it, right, this is going to be the bullet point. An application point is we're looking at the radius of a tube playing a big factor in what we do and how people breathe. So flow is directly related to pressure and radius. So flow is profoundly affected by the radius of the tube, right? So here we go to our fire hydrant hose and our garden hose analogy, right? Here you have your milkshake in front of you, hopefully still, or you finished it. Good for you either way. All right, so you have your milkshake analogy. We go from a big tube to a small tube. If we have that flow, if we change that pressure, the amount of milkshake going through that straw per minute will increase the more pressure we give it, or if we decrease the amount of suction pressure, it will decrease the amount of gas or the amount of milkshake going through that straw per minute. So Poiseuille's law, when we arrange it for flow, should be a little V with a dot over it here. When we arrange it for flow, right, if we are going to have pressure directly affected. So if we have a change of radius, that means we're going to have to use more pressure. Okay, if we go from a big tube to a small tube, we're going to have to use more pressure. All right, now let's say we give this patient over here a bronchodilator, right, in this milkshake straw analogy. We give them a bronchodilator. In other words, we expand the size of their airways. So we make their airways back to a bigger size again. Then we don't have to use near as much pressure. We can get more fluid, more laminar flow through there. right? We're going to have a lot easier time. So when we're setting this up for flow, it's directly related to the pressure and the radius, okay? So the smaller the tube, the more pressure and less flow can get through there, right? So if you're looking smaller the tube, more pressure can get through there, more pressure there is. And then the bigger, the more wide open, the larger the radius, the less pressure and the more flow can get through there, right? So if I had my giant down here, giant fire hydrant hose, tiny garden hose, right? It's going to take a lot more time, a lot more pressure to get the flow of water through this tiny hose. Over here, the molecules are more spread out, there's less pressure, and it's easier for gas to flow in a more laminar way. So when we have patients that have their lungs start to close down, like what we see with this small garden hose type situation, it's going to be hard. It's going to take a lot of pressure, and the volume of gas that they're exchanging, the volume per time, right, that flow of gas, is going to be decreased. Therefore, they can get hypercarbic. They can retain CO2. It makes it a lot harder for them to breathe, not only to move gas into and out of their lungs, but also, right, it's going to make their respiratory muscles work hard, which we all know those are skeletal muscles and they can fatigue pretty easily. So they'll retain CO2 and they can go into respiratory fatigue or failure pretty easily. All right, so this is sort of an application of what we were just talking about, assuming the pressure remains constant. Okay, so here's your milkshake over here and over here. Right, over here, if we're using the same suction pressure, over here I have a giant straw, and over here I have a small straw. If you're using the same suction pressure when you're drinking out of these different size straws, what's going to happen, or calculate what change will happen to the amount of milkshake going into your mouth, right? So assuming your pressure is constant, right, you're using the same suction pressure, and we reduce the size of the straw by half, right, our radius is decreased by half. This is going to be a 16-fold change in your flow rate. What does that mean? Okay, so over here, and I can just use the numbers from the example here. I have a 1 centimeter radius straw, and over here I have a 0.5 centimeter radius straw. Okay. So I have a smaller straw and a big straw. Okay. So now I go from a big straw to a small straw. My big straw falls on the floor. All they got are small straws, and it's half the radius. Okay. So what happens if I'm using my same suction pressure to how much of that milkshake goes into my mouth, right? So as it reduces, as I get the radius reduced, I'm going to have to also see that I'm not going to get near as much of that milkshake in my mouth. Okay, so if I have a flow, and let's just say I love having, to satisfy my taste buds, I need 16 mLs per second to flow into my mouth. That's what my taste buds like. That's what my esophagus likes, right? That's what helps me avoid having an ice cream headache, right? 16 milliliters per second. And now I go to a smaller straw because my big straw fell on the floor for some reason. I'm going to have a significant reduction in this flow rate. So how do I calculate this, Derek? Well, if I ask you, what will be the new flow rate if I reduce the radius, if I cut the radius in half, what will happen to the flow rate? And you will say, okay, what was my original flow rate? Well, if your original flow rate was 16 milliliters per second, and it gets reduced by 16-fold. Now, where does the 16-fold come from? Well, that's radius to the fourth, right? This is the exponential relationship that we were looking at earlier. So 4, 8, 12, 16, right? That's an exponential change. So that's where that 16 comes from. So if I ask you what the new flow rate will be, and we're going from big to small, you divide by 16. if we're going from small to big, you multiply by 16, okay? So here, I'm going from a big straw to a small straw, right? And I cut my radius in half. So I'm dividing by 16. So 16 over 16 equals 1. So my new flow rate will be 1 milliliter per second. That's a big difference. Normally, I was getting 16 milliliters per second into my mouth and on my taste buds, and now I only got 1 ml per second on my mouth and my taste buds, right? So this is going to be a big decrease. I'm going to be very disappointed because now I don't have near as much of this delicious beverage going onto my taste buds. Hopefully this is starting to make sense. So a smaller tube, a smaller radius means our flow rates, if we're using the same amount of pressure, the same amount of suction pressure, we're not going to get near as much gas, right? If we have lungs that are closing down, we're not going to get near as much gas into or out of our lungs. Well, this is what we do with people that have obstructive lung disease like asthma, emphysema. We're going to have them do what's called pulmonary function tests, where we look at the flow of gas. If the flow of gas out of their lungs is really, really low, then we know that their obstruction is really, really high, right? That's exactly what we're looking at here, is what happens to the airways with asthma, right? They get smaller, the radius gets smaller, right? With emphysema, with their floppy airways, what happens with the radius? It gets smaller. So when we're looking at those disease conditions, it's actually an application of Posey's law here, and we'll equate it to airway resistance in a bit here, but that's exactly what we're looking at. The flow of gas out of their lungs is significantly reduced, which means their ability to get rid of CO2 decreases, right? So we can also not only arrange it for flow, but now we can arrange it for pressure. Okay. So when we're arranging it for pressure, flow is constant. So let's say in our previous analogy, I want to get, arranging it for pressure, our flow is constant and radius is to the fourth. So pressure is directly related to the flow and indirectly related to the radius. So pressure is profoundly affected by, and remember I told you this was the big thing, what's the exponential relationship in this equation, right? By the radius of the tube. The radius is the exponential factor in this relationship. It's the polarizing factor there, right? So as we arrange it for pressure, right, we're going to see that our flow over our radius. So this is where you're going to pretty much take whatever it is and divide it over 16. So let's get to the example here. So assuming flow remains constant, if we decrease the radius by half, we go from 1 centimeter, if you're looking at the picture here, 1 centimeter to a half centimeter. Okay, so here we're going to draw our milkshake with our straw. With an even smaller straw, that's a smaller straw. Okay, so if assuming we have a constant flow rate, so now here I am going to say, no matter what, I want 16 milliliters per second, because that's what my taste buds want, right? So my flow of fluid is constant. Okay, so now assuming I want the same amount, no matter what size straw I have, you know this, right? You can try this right now, right? Get a really thick drink with the straw, and then drink it with the straw regular lumen, and now reduce the lumen in half, right? Pinch the straw a little bit. You're going to have to work harder. You're going to have to use more suction pressure to get that same flow of milkshake, that same flow through that straw. So this is saying the same thing. This is saying exactly like what you just experienced by drinking that milkshake and pinching the straw a little bit. You are experiencing that as the radius decreases, it's going to take more pressure to get the same amount, right? It's going to take more pressure to get the same amount. That's exactly what's going on here, right? You're going to have to work that much harder with a smaller straw. So when someone has a bronchospasm, when they have a floppy airway, they're going to have to use more respiratory muscles to get the same amount of gas into or out of their lungs, right? This is also a 16-fold relationship. So if I have a driving pressure, right, over here with my large straw or my normal straw, I was using 1 centimeter of water pressure. Well, I might ask you, what would be my new change, or what would be my new pressure needed to get the same flow rate? So this is pretty easy. I'm going to take my pressure times 16. Remember, this is radius to the 4th, which should equal my new driving pressure of 16. So that's how much pressure I need to give or need to use to get the same 16 mLs per second out of the smaller straw than I was using with the normal size straw, right? Isn't that crazy? So if I ask you this in the future, I'll ask you, hey, what would be my new pressure needed to get that same flow rate? You're just going to multiply it by 16. Okay, so in this example, right, it's reduced by half. We're going to multiply it by 16, so our new driving pressure, and it's already there, right, because I used the same numbers, right, with the new, to maintain the same flow rate. I'm going to change my pressure needed to get to 16 centimeters of water pressure. Hopefully this is starting to make sense. Hopefully you're experiencing this at home with a nice, cool beverage and enjoying the experimentation that is physics. All right, so what stops someone from exchanging gas? Well, there's two big things. There's frictional forces and tissue viscous resistance, as well as airway resistance. So tissue viscous resistance is something you need to not forget about. In other words, you need to remember that this can also happen on your patients. Patients with morbid obesity, patients with pulmonary, fibrosis, ascites. I've even seen burn victims where their skin was burned so tightly on the thoracic cage it restricted their lungs from expanding. Third trimester of pregnancy is a classic example here. Pleural effusion, where there's a bunch of fluid that builds up in the pleural space, can really restrict the lung tissue from expanding. So I had a patient once, car accident, ejected, came into the hospital, and we just could not fill their lungs up. We could not get gas to really fill their lungs up. It was taking so much pressure to fill their lungs up. Well, they thought it was a pneumothorax. They thought that they had a hole that opened up in their pleural space. And so they put in a chest tube to relieve the pressure there, and it didn't do anything. It still took a lot of pressure to inflate the lungs. So we asked what the bladder pressure is. The bladder pressure was high. It was through the roof. They put a Foley or a catheter in them, and it was really high. So their abdomen was really tough, right? It was a really hard, thick abdomen, and what was happening is there was blood filling up the abdominal cavity that was restricting the ability for the lungs to expand, right? It was pushing up on the diaphragm. It was pushing against all that stuff. You'll even see this with kyphoscoliosis, where it just pushes the lungs in and it just impedes the ability for the lungs to expand altogether. So there's a bunch of things that can cause this. Now, in that case of the trauma victim, all they did was open up their abdomen and relieve that blood pressure, relieve the pressure that was in that abdominal cavity, and then we're able to ventilate normally. So don't ever throw this out, right? That could be something going on. So airway resistance would be your other thing. This would be the resistance of gas flowing through the airways. So when we're looking at this is something like what we'd see with a disease condition like COPD or asthma. So down here, we're going to draw a pair of lungs and a trachea. So when we're looking at airway resistance, usually it's that tube leading up to the lungs, right? Or the tubes in the lungs themselves, right? We're not looking at the respiratory zone. And over here on tissue viscous resistance, it's really nothing to do with the tubes. It's all about the external pressure being pushed against the lungs, someone bear hugging the lungs, right? We have someone bear hugging the lungs and squeezing them in super tight, like what you could see with a kyphoscoliosis, right? Squeezing the lung tissue or third trimester of pregnancy, where it starts to impede the ability to expand, right? that could really limit someone. So down here, airway resistance would be more, hey, we're pinching off the hoses, and up here with tissue viscous resistance, we're reducing the ability for the lungs to expand. Like here, let me draw in a pleural effusion, right? Bunch of fluid that builds up in the pleural space. It's going to really limit the expansion of the lung tissue altogether. So airway resistance is going to be something we'll calculate with each individual patient that we see in the critical care unit, and even outside the critical care unit as well. So this is the difference between the mouth and the airway pressure divided by the flow rate. So hopefully you're like, what in the world, right? This is how much pressure it takes to get gas to go through the airways, okay? So when we're looking at this one, the equation is your change in pressure over your change in flow, and this is in liters per second. Liters per second. Okay, so change of pressure over flow in liters per second. Okay, so when we're doing this, this is also known as raw, R, resistance, and then AW, sub AW, airway, right? Resistance to the airway. Your unit of pressure, and I love making sure you know your units, because if you know your units, then you actually know the calculation. So what's the calculation? Well, I have my pressure, which is centimeters of water pressure, over my flow rate, which is liters per second, right? So my unit of measurement is centimeters of water per liter per second. Hey, if all I remember is my units, then I know how to actually do the equation, because when we go up here, my pressure's in centimeters of water pressure, and my flow is in liters per second. So if I know that raw is in centimeters of water per liter per second, then I know my calculation is pressure over flow. So your unit of measurement, centimeters of water per liter per second, a normal raw is 0.5, and this is assuming they're not intubated, right? 0.5 to 1.5 centimeters of water per liter per second. This is for a spontaneously breathing individual. Now you'll see some sources that differ from here, but this is where Desjardins wants you to memorize this. So normal raw, 0.5 to 0.5 to 1.5 centimeters of water per liter per second. It's higher in newborns. Well, why is it higher in newborns? Well, when we look at newborns, until you're about 6 months old, your mouth is for suck swallow, your nose is for breathing. Well, according to Posey's law, right, your nose compared to your nose is a much smaller radius than your mouth, okay? So when we go from a large radius to a smaller radius, we just went over this, we know that the airway resistance, or how much gas can flow through there, decreases because we got a smaller tube, right? We got a garden hose compared to a fire hose, right? Big difference. So with newborns breathing through their nose, they're called obligate nose breathers till they're about 6 months old. And that's why if a kid comes in, a newborn comes in, and they're working hard to breathe, one of the first things you're going to do is suction out their nose, because we know that if there's a lot of mucus or anything weird up there, that's what's causing that can cause a lot of problems, okay? So that's why newborns have a super high, right? Not only that, but how small are the radius of their airways compared to the radius of your airways, right? So when we're looking at this, there's a lot of reasons for their air resistance to be that much higher. COPD patients. So when we're looking at patients that have chronic obstructive pulmonary disease like emphysema or chronic bronchitis, or even asthmatic components to these patients, their raw is going to be higher, because remember we talked about emphysema, how their airways are floppy. They lose cartilaginous structure because smoking, right? A lot of bad things ultimately happens. They lose that structure. So when they exhale, their airways prematurely close because they lost that structure. And that means we're going to trap gas. We're going to have a smaller radius, right? If we lose that structure, we lose that scaffolding, then our radius decreases. And so they're going to have a lot harder time getting rid of gas, and it's going to be a lot more retention of CO2 because they're not going to be able to get rid of a lot of gas ultimately. A deviated septum, that's where part of the nose is. Obviously, the septum of the nose has been modified from its original condition. Usually these are post-trauma victims. You'll see that. And it makes it a lot harder for them to breathe through their nose especially. So it's going to be a lot more airway resistance. Even bronchoconstriction, right? Someone has severe asthma, that bronchospasm can really cause a big issue here and make it a lot harder for them to get that breath into their lungs. Okay, so let's do some practice calculations here. So air resistance, remember, is pressure over flow. Okay, so if you're generating a flow rate of 4 liters per second, so over here I'm going to draw my calculation. Pressure over flow in liters per second. All right, over here I'm generating a flow rate of 4 liters per second, so I'm going to draw that in, 4 liters per second. And my trans airway pressure is 4 centimeters of water pressure, so I'm going to put that in here, 4 centimeters of water pressure. Right? What is my airway resistance? Well, this is pretty straightforward. I got pressure over flow, 4 over 4. I love the math here because that means my airway resistance is 1 centimeter of water pressure per liter per second. Whew, it's a long unit, but there you go. So here's my question. And obviously that's the answer here, right? 1 centimeter water per liter per second. So here's my thing. I'm going to ask you to calculate this, and then I'm going to give you the question. All right, you just calculated this. Is this normal, high, or low? So we're looking at this. What's a normal? Well, a normal is 0.5 to 1.5 centimeters of water per liter per second. So this is a normal airway resistance. Okay, nice. Okay, so when we're looking at this, flow rate in general with our equipment that we use, here's breaking some bad news to you, is recorded as liters per minute. Remember in the calculation, we need to record it as liters per second. So we need to make sure we have the answer in the correct unit when we're doing this. And this is usually a big mistake that I see on the exam, is obviously you will be doing this on your exam. People don't convert the flow rate to liters per second from liters per minute, and then they end up getting the answer wrong. So let's do another example. This one's going to be more applicable. Hey, we got a machine, a pulmonary function machine, and it records the flow rate at 90 liters per minute. Okay, that's more realistic of what you'll see in the world, because that's how it's done usually. All right, so before I do this, I know I'm being asked to calculate airway resistance. Well, what's my calculation? Change in pressure over flow in liters per second. Okay, so my next part here is to plug in my numbers. So pressure generated is 6 centimeters of water pressure. And then I need to put in my flow in liters per second. But my flow is in liters per minute. So instead, and here's my recommendation. Okay, this is just my recommendation from however many years I've been teaching this. Convert it now before you do the whole equation, otherwise at the end you may not remember. So when you're doing this, I would take 90 over 60, right? Because you got to convert minutes to seconds, right? So that's how we do it. We divide it by 60. So 90, we're going to convert liters per minute to liters per second, right? And when we do this, it should equal 1.5 liters per second. So 6 over 1.5 liters per second. So you can see why I was purposeful at drawing in my units there for the equation. So when I actually do the equation, 6 over 1.5, I equal, and you guys can do this yourself, so pause it, do the equation yourself. If by hand would be awesome. Hopefully you got 4, right? So what's your unit down here? My airway resistance is 4 centimeters of water pressure per liter per second. So the next thing I'm going to ask you to do is then tell me, is this normal, high, or low? Well, you're going to say, well, this normal is 0.5 to 1.5 centimeters of water per liter per second. So this is high. This is an increased airway resistance. Okay, so now you've told me that the airway resistance is high. Now I'm going to tell you, give me an example of what can cause this. Oh heaven. So this is where you got to think, okay, what would increase air resistance? Well, asthma would be one, right, where the airways get smaller. Emphysema could be one, where the airways get floppy and decreases the radius. Inflammation of their airways could be a cause. They could have aspirated a foreign body, like some food or an object that they're, especially a kid. So there's a bunch of different things, or there could be a giant mucus plug, right? There's a bunch of things that could cause their airway resistance to increase. Swelling, bronchospasm, floppy airways, anything that reduces the radius of the airway can easily cause their bronchospasm or cause their airway resistance to increase. So not only do I want you to know how to calculate it, but also I need you to know if it's normal, high or low, and then what could cause it to be normal, high or low. Okay, and I'll ask you to do the same with compliance. I'll ask you to calculate lung compliance when we get there and tell me if it's normal, high, or low, and what could cause it to be that direction. Okay, air resistance works against the flow of gas, right? And remember, it's how hard it is to gas to get through that area, right? The smaller the hose, the more turbulent that flow is, right? Just like we talked about the garden hose versus the giant fire hydrant hose, right? Big difference. So the smaller the radius, the more the patient works to breathe. That's the WOB, is work of breathing. So it makes it very hard for those patients to breathe overall. So when we're looking at this, we're going to look at our physics terms from science class. When we're looking at different terms, we'll start with laminar. So laminar is the streamlined parallel gas flow. It's low flow rates, low pressure gradients. This is great for your lower airways. Now your upper airways, they need to be turbulent, like your nose and stuff, to help filter heat, humidify. Right, we need more dwelling time up there to help do all those functions. But the further down, the more our function changes, the less we need it to dwell, and the more we need it to be more streamlined. The random high flow rate type of gas flow rate is turbulent. Right, we already talked a little bit about turbulent gas when we talked about the heliox mixtures. And then finally, we have a mixture sort of in between the two, and it's called transitional flow. Transitional flow is a combination of laminar and turbulent flow, and this usually occurs in your branching airways, right? So this is that transition from your upper airway turbulent gas flow to your lower airway turbulent gas flow. You might ask, why do I need to know this, right? Well, when we're looking at this, when we intubate someone, let's say we have someone with severe asthma or severe emphysema, and we intubate, we bypass their mouth and their upper airway, yeah? Right? We go below their vocal cords, right? The tube extends below their vocal cords. When we do this, we bypass their nose, their mouth, and the upper airway. Well, what happens to their airway resistance if we bypass the normal nose, mouth, and upper airway? Well, 50% of your airway resistance right now is your nose, your mouth, and your upper airway. Therefore, if we bypass this, right, if we move past the nose, mouth, and upper airway, we reduce the airway resistance that patient has to breathing. In other words, we make it easier for them to breathe. Even though we're sticking a tube in their trachea, we're making it easier for them to get gassed more laminar down to the respiratory zone and out of the respiratory zone. We're making it more laminar. We're making it easier for them to ventilate when we bypass the nose, mouth, and upper airway. 30% of your raw will come from your trachea and your bronchi, and then the last 20% there will come from your smaller airways. So overall, that makes a difference when we're looking at big airways versus small airways, and why bypassing the upper airway might have reduce how much their body has to work to breathe. So what important changes occur in the airway of an asthmatic patient that increase resistance? Remember, they go from a wide open airway to now a bronchospasmed, much smaller, much more narrow airway. So they're going to, according to Posey's law, they're decreasing the radius significantly. So this is going to cause an increase in resistance, right? So what medications do we do to reduce airway resistance? Well, in asthma, are we going to use a sympathetic or parasympathetic agent? Well, we'll use something that has sympathetic effects, right, to help relax that bronchial smooth muscle, right, that part there. We'll also look at inflammation that being a part of asthma too, and that could be, if it's severe enough, systemic, or steroids that go through your bloodstream versus inhaled steroids. And inhaled steroids is something that they're using more and more now too. So that can help reduce the airway resistance that patient's using to breathe, right? We're dilating, we're allowing that lung tissue to expand, we're allowing for a bigger radius when we give them that bronchodilator to allow them to breathe a little bit easier. Now let me ask you this. We talked about this a little bit earlier. What might be an advantage of using a gas mixture of helium and oxygen instead of your normal medical grade air, which would be nitrogen and oxygen? Well, what are we doing to the type of gas flow? What are we doing to the fluid dynamics of the gas? Well, the fluid dynamics change because now we have a very turbulent gas flow that's going through this little narrow airway. And if I give them helium with oxygen instead of nitrogen with oxygen, I'm replacing that nitrogen part with helium. If I give them that helium part to it, then I'm reducing turbulence. And therefore, even though the airways are small and narrow still, right, we're waiting for those other things to kick in, I'm allowing for a lot more laminar flow to make it easier for gas to go into and out of their lungs, so they don't have to use near as much pressure, and they don't have to use, and their tidal volume doesn't have to be affected as much either. So it's very helpful for those patients. All right, time constants is where we put both of these things together. So all together, time constants is compliance times airway resistance, or air resistance times lung compliance. It'll work either way mathematically. And this is how long it takes to fill or empty the lungs, ultimately. Okay, so if you go get a shot glass and a regular size cup, you can play along, right, if you want to do a little experiment with me at home to sort of be more hands-on with this and get an application. So small glass, big glass, okay. Then I also want you to go back and get your straw from your milkshake. Hopefully you're having a delicious good time here, right? Go back and get a big straw and a small straw, right? And then let's look at this. All right, if an individual has an increase in their airway resistance, what will happen to how long it takes to fill their lungs? Okay, so here we have a bucket or a cup. Here we have the same sized cup. So these cups, same size. Over here we have a normal straw, and then over here we have your tiny straw. We're trying to fill these cups, or we're trying to drink out of these cups. Which one, if we have a smaller straw, what happens to the time it takes? Right? What happens to the time it takes to drink this milkshake? If we have a smaller straw, it's going to take a lot longer to drink this milkshake with a smaller straw than it is with the big straw, right? Just like if these were hoses, right? If you have a large hose and a small hose and they're both trying to fill a bucket, which one's going to take longer to fill the bucket? Well, the small hose is going to take longer to fill the bucket because your flow of gas is smaller. So if you have an increase in air resistance, which would be the size of the straw or the size of the hose, it's going to take a lot longer for you to fill the lungs and a lot longer for you to empty their lungs. right? So this would be a long time constant. Okay, now we're doing some more application here. If an individual has an increased compliance, will the time it takes to fill their lungs increase or decrease? Okay, so here is where you use your big cup and your shot glass, your small cup, or whatever, right? You have the same size hose, same size straw, right? Nothing's going on with the raw. The raw is equal between the two. But now we're looking at the stretchy, right, how stretchy or how big of the container we're looking at here. So compliance we're going to equate to as the size of a container for the purposes of this lesson. So we have a big cup and a small cup. If you have increased compliance, that means your container is bigger, right? If you have an increased compliance, what will happen to how long it takes to fill that big container? So you should know, if I have two of these hoses and they're both the same size, filling up this bucket, one's a big bucket, one's a small bucket, which one's going to take longer to fill? Well, the big one, of course, right? It's going to take longer to fill and longer to empty. As you know from shot glasses, doesn't take long. So when you're looking at this, when someone has a high compliance, very stretchy lungs like emphysema, this is going to be called a long time constant, right? Increased or a long time constant, because it's a bigger container. It's stretched out. It's lost its elasticity, so it can accept more volume. It's a long time constant, which means when we put these people on mechanical ventilation, we're not going to want to set a really fast respiratory rate, right? If we have them breathe really rapidly, remember they're going to take a long time to exhale. And so if we set a really fast breathing rate, that actually can cause them to build up gas in their lungs because they won't empty it as much. Isn't that crazy? All right, more application. All right, if an individual has decreased compliance. Okay, so here we go back to our containers. Large container like emphysema, and then shot glass. Both has the same size straw, right? If an individual has decreased compliance, that would be like your shot glass, right? It cannot accept a large volume. It is resisting expansion, right? If an individual has decreased compliance, like pneumonia or pulmonary fibrosis, or could even be something like a pleural effusion that's restricting lungs expansion, right? So if you have decreased compliance, will the time it takes to fill their lung be increased or decreased? So if you have a big cup and a small cup, which one, if you go from a big to a small, which one is going to fill up faster? Which one will empty a lot faster? If we have a shot glass and a milk jug, which one's going to fill up faster? Which one's going to empty faster? Well, of course, the small one is going to fill up faster and be emptied faster. So if the more restricted our lungs are, the shorter the time constant. Okay, more application. If an individual has decreased airway resistance, will the time it takes to fill their lungs increase or decrease? Okay, so here we have the same cup, same size cup. Okay, the individual has decreased airway resistance. So decreased airway resistance. What will happen to how long it takes? Okay, so here we have our small straw. And we gave this patient a nice dose of albuterol, good sympathetic stimulator. So we go from small to big. So we have a now nice fire hydrant hose. Previously we had a garden hose. What will happen? What will happen to the length of time it takes for them to fill up or to empty their lungs? Well, this is more wide open, so of course it's going to be a lot faster to fill up that hose, fill up that cup. It's going to be a lot faster to drink. It's going to be a lot faster to get rid of it. So this will be a shorter time constant. Okay, so when you're looking at this, this is compliance. times airway resistance, right? That's the whole equation into this. So this is just showing the equations, compliance times airway resistance. So this is something we do calculate, and especially we use for critical care medicine to set how long of an inspiratory time to use on a ventilator, or how long in between each breath we let the gas back out. So this is something we actually do use when we're looking at critical care medicine. So there is application for this. So how will changes in airway resistance and compliance impact time constants? Well, if the airway resistance doubles, the time constant will also double, right? Double. All right, so remember it's raw. Here, let's go to yellow. Raw times compliance, right? So if we increase one of these factors, which is raw, then of course your end result will also be increased. So if we have a lumen and we make that lumen even smaller, right? We have that radius of the tube, our airways become even smaller, then of course we're going to have a doubling, right? If our air resistance doubles, then our time constant, or how long it takes for a breath to go in, or how long it takes for a breath to go out, will also double. If your compliance is reduced by half, the time constant will be reduced by half. Remember, the lower the compliance, right? That's more of your shot glass thing. The smaller the container, the shorter time it takes to fill it up or empty it, right? So if compliance is reduced by half, the time constant will also be reduced by half as well. So this is just showing that direct relationship. If either of these increases, then your time constant will increase. If either of these decreases, then your time constant will decrease. All right, breathing patterns. This is based upon your tidal volume and your rate of breathing. So this is the relationship between the two. We call inspiratory to expiratory ratio. So how deep and fast you breathe will affect your breathing patterns. So if the volume of gas that normally moves into and out of the lungs in one quiet breath is about 5 to 7 milliliters per kilogram of ideal body weight. All right, 5 to 7 milliliters per kilogram per ideal body weight. Okay, so when you were looking at setting a tidal volume on a patient on a ventilator, you guys are learning this now. When we go to set someone up on a breathing machine, roughly, if we want to give them a normal physiologic tidal volume, we're going to set them up roughly at 6 mLs per kilo per ideal body weight. So we look at their ideal body weight based upon their height, and then we set a tidal volume, right, how big of a breath to give them based upon their ideal body weight, not upon their actual body weight, but on their ideal body weight, because we're looking at the thoracic size, right? We're looking at the thoracic cage and how much volume their lung takes up within that thoracic cage. So roughly about 6 mLs per kilo might be a good place for us to start with some of these patients. So the normal adult rate is around 12 to 20 breaths per minute. So that's what we're looking at for adults. Well, a normal neonate, much faster, around 30 to 60. So this is something that happens with how small of a breath they're taking. So they're taking much smaller breath. They're still breathing about 5 to 7 mils per kilo per their body weight. But us, since we're able to have a lot less airway resistance associated with our breathing, we can actually breathe a lot slower and have better volumes with it as well. Plus their rib cage isn't as formed as our rib cage, and so that's going to affect their volume expansion as well. So what's an IDE ratio? Well, that's your ratio of inspiratory time to expiratory time. And this is a ratio. So normal is 1 to 2. 1 to 2. So for every 1 second you'd breathe in, you would breathe out 2 seconds. So this is your normal IDE ratio. Well, and when we're looking at this, gas flow actually is a 1-to-1 ratio, both into and out of our lungs, but normally we pause at end exhalation before the next inhalation. So there are actually sort of 3 phases when we look at breathing besides inhale and exhale. There's inhale, exhale, and a little bit of pause at end expiratory, and that sort of creates that 1 to 2 ratio. So even on life support, we'll put patients on a 1-to-1 ratio. And in certain situations, right, this is not something we do all the time, but we can put patients in 1-to-1 ratio, IDE ratio, and they'll still be just fine because we're looking at gas flow being more of a 1-to-1 ratio, but normally, I want you to remember a normal IDE ratio is 1-to-2. When you look at something like emphysema that has a long time constant, it could be 1-to-3, 1-to-4 when we look at those guys. All right, I love this graph. I know you may not love this graph, but this graph looks at your depth of breathing and what it really means. So when we're breathing, normally, remember, we have to get gas through our conducting airways, through our transition airways, and then ultimately to our respiratory zone. So we're going to lose some of the gas normally. That there will be gas that will not make it to a respiratory zone, just like there will be gas that gets transferred from your bloodstream to your alveoli that during one breath will not make it out of your lungs completely, right? There's going to be some that sort of gets caught up in the transfer between in and out. And so this graph is great at looking at hypoventilations where you breathe really shallow. And so if you're looking at this graph, go to purple here. If you're looking at this graph, hypoventilation means you're breathing very, very small breaths. So that's like a tidal volume here of 250 mLs, right? Very, very shallow breathing. And that means there's a term here called dead space ventilation. So if you look here, dead space ventilation means there's gas that doesn't get exchanged with your bloodstream. So we have ventilation without perfusion. So there's gas moving, but there's no exchange with the bloodstream, right? There's no exchange of CO2 and O2 with the bloodstream. So when you're breathing really shallow, like right now, if you were to just pant, right, really shallow breaths, most of the breathing that you're going to be doing, most of that gas will not make its way deep into your lungs, deep into your respiratory zone. It'll just sort of stay in your conducting airways, right? Try it right now. Take some shallow panting breaths, right? Do that for a little while. It's just going to stay mostly in your conducting airways. And therefore, you're going to have what's called dead space ventilation. In other words, you're not going to be exchanging enough CO2 and O2 with your bloodstream. So when people breathe really, really, really shallow, it's actually a bad thing. That means there's more dead space ventilation. It means they're not getting rid of or getting enough oxygen, getting rid of CO2 or getting enough oxygen into their bloodstream. So hypoventilation, breathing shallow. Normal ventilation, let's just say in this patient, 500 mLs is a normal volume. So normally you're going to have a little bit of that volume here. That will be a dead space ventilation, but most of it will actually exchange with the alveoli. That's what you're looking at on this vertical graph. So we'll lose a little bit, but most of it's going to be exchanging with the bloodstream, right? So that would be normal ventilation. Hyperpnea, which means a big breath, means if we go even deeper, right? If we take a super deep breath, like we're about to yawn or blow out some candles, that means most of our breath will actually be to exchange gas, right? So that means we could, in theory, get rid of a lot of CO2 because we have less gas getting wasted in the transfer between our alveoli and our mouth. So hyperventilation is where we exchange a lot of gas, and therefore it reduces the CO2 level. So hyperpnea is just a big breath. Hyperventilation is where you blow off a lot of carbon dioxide from your bloodstream. So this is a graph also looking at not only how deep of a breath you have and how it compares to what's called dead space, but also your IDE ratio, right? The patient's breathing into a 500 tidal volume, and then out, and then in, and then out. But you remember, there's this little pause up here. That's that end expiratory pause. So minute ventilation. I bring this up because we want to look at, over the course of a minute, how much gas is exchanged between the bloodstream and the lungs, right? How much over the course of a minute, not just one single breath you have, but over the course of a minute, how much gas is exchanged, right? So when we breathe, you have a combination of how much gas you get exchanged between how deep you breathe, which is your tidal volume, and then how much you breathe, which is your respiratory rate, okay? So when we put this together, we call it minute ventilation. So the average volume of gas entering or leaving the lungs per minute, usually this is in liters per minute, right? So minute ventilation, the calculation for minute ventilation is tidal volume times your respiratory rate. right? That's it. That's the whole calculation. And I will expect you to calculate this. This is on the worksheets for you to practice. So it's just tidal volume times respiratory rate, and that's how, over the course of a minute, how much gas are you exchanging? Well, a normal minute ventilation for an adult is about 5 to 10 liters per minute, right? If you're hyperventilating, that could be 20 liters per minute, right? So on and so forth. All right, minute ventilation in restrictive lung disease, that means your lungs are scarred up, or that means that you have a fibrosis, or that could even mean something's restricting it, like your kyphoscoliosis that's squeezing in on the chest wall, right? So if we have this, it's going to equal a decreased compliance, right? So if we have decreased compliance, right, that means we'll have a short time constant. Right, we'll have a short or decreased time constant, which means our tidal volumes are going to be very, very small, right? We can't expand that lung tissue much at all. So in order to have the same 5 to 10 liter minute ventilation, our body has to compensate by increasing the respiratory rate. Remember, minute ventilation is tidal volume times respiratory rate. So if our tidal volume decreases, in order to get the same minute ventilation, we have to increase our respiratory rate. I hope that makes sense. So if you walk into a patient's room and you see them breathing really fast and really shallow, you know they have a restrictive lung issue going on. Something's restricting the lung from expanding, whether it's a severe pneumonia or a pleural effusion. Something's restricting their lungs from expanding, and that's why they're breathing so fast. What about obstructive lung disease? Well, with obstructive lung disease, we talked about this, where they break the elastance of their respiratory zone and they have an increased compliance. So that would mean that they have a long or an increased time constant. It takes longer for a breath to go in and longer for a breath to go out. Because their containers are bigger, right? We talked about this in the time constant, right? They have a bigger container. They have bigger lung volume. This is your bigger cup, right? Because they have that bigger container, they have that increased tidal volume. So remember the minute ventilation, we have our tidal volume times respiratory rate. So in this case, our tidal volumes are big. So in order to avoid hyperventilation, right, to maintain equilibrium, these patients will actually have a lower respiratory rate to maintain their minute ventilation. Right, hopefully you see that that's just that balancing out that equilibrium to get that normal minute ventilation. All right, so why we're talking about this, it's important we talk about Auto-Peep. And what's Auto-Peep? This is, PEEP means positive end expiratory pressure. This is how much pressure there is left over in the lungs at the end of a breath, right? So patients with increased airway resistance and compliance have increased time constants, right? We talked about how if you have someone with asthma or someone with a stretched out container like emphysema, they have an increased time constant. It takes longer for a breath to go in and longer for a breath to go out, right? So if there's not enough time for that breath to come out, okay, if we prematurely give them a breath, the next breath before they're done exhaling the previous breath, then there's going to be a lot of gas trapped in their lungs, and that creates pressure, right? That extra gas trapped in the lungs creates pressure, and this is why we call it Auto-Peep, right? It's also another thing that we might call air trapping, right? If you talk about air trapping, that would be emphysema, asthma, or there's another term called Intrinsic Peep, and there are even ventilators that look at PEEP intrinsic, right? That they actually reverse the terms, but it's intrinsic PEEP they're looking at. Occult PEEP I've seen out there too in some of the literature, inadvertent PEEP or covert PEEP. I even seen the term sneaky PEEP at one point. So there's a lot of different terms for the same thing. All those mean the same thing. It's how much gas got trapped in their lungs before from the previous breath to now the next breath, right? So that means they didn't have enough time to exhale, and then all of a sudden a new breath was being delivered to them. This happens with asthma. This happens with emphysema, and that's one of the most important things we could do when we put those people on life support, is to make sure they have an adequate time to exhale. They have an adequate time to get rid of gas from their lungs. So Auto-Peep actually makes it harder for you to breathe. It increases your work of breathing because you have a lot of gas left over in your lungs, right? So remember, we talked about that gas being pressure, but also we could talk about it being a capacity as well. So it increases your functional residual capacity, and therefore hyperinflates your alveoli. So here's your alveoli, and then it just progressively hyperinflates the alveoli because the gas is being trapped. And then the next breath, even more gas gets trapped. And the next breath after that, even more gas gets trapped. So it's building up and hyperinflating the alveoli. The diaphragm eventually flattens out. So your diaphragm normally is that dome shape. Eventually it flattens out. It makes it harder for the diaphragm to move and create a pressure gradient. Remember from the first part of the ventilation in chapter 2, this is a big part, is creating that pressure change using your diaphragm. And if your diaphragm is not moving at all, you're not creating a pressure gradient hardly at all. And this is a very serious condition. This means these people, once they get a severe enough FRC, a big enough FRC, they're going to have a lot of difficulty getting gas into and out of their lungs. So patients with obstruction like COP and asthma don't have enough time, if they're breathing fast, to get that gas out of their lungs. So we have to focus on getting these patients to exhale, right, with the technique called pursed lips breathing. So you can do this now. If you take a deep breath in through your nose, like you're smelling flowers, and then you're blowing out, like you're blowing out candles, you purse your lips as you blow out, you're going to feel that back pressure, right? If you purse your lips as you're blowing out right now, you're going to feel back pressure, and that back pressure helps really lengthen the expiratory time, so that way you won't have as much gas be trapped in your lungs. So it gives you a longer time to exhale before you take your next breath in, and helps relieve some of this air trapping. Dead space. So dead space is ventilation without perfusion. That is a definition you need to remember in this course and many courses after this one. So this gas is not NOT. This is not effective in gas exchange. So there are three types of dead space that you have. You have anatomic dead space. So this is the gas in your nose, your mouth, your trachea, your main stem. That's anatomic, right? There's no CO2 and O2 getting exchanged in there. Those are conducting airways. So it's just your anatomic dead space. That's no ventilation taking place there. It's just the movement. The bulk movement of the gas is all that's going on there. So you have ventilation, you have gas movement, but there's no exchange of CO2 and O2. So that's anatomic dead space. We have ventilation without perfusion, right? Anatomic dead space. Alveolar dead space means that the alveoli is inflated, but there's no perfusion. So here we have an alveoli, and then blood flows past it, right? Normally we have just blood just flowing past this alveoli. Well, let's say we have a severe hyperinflation situation, and this patient's air trapping a lot, and so it actually pinches off blood flow to the respiratory zone. It pinches off that blood flow. It's so expansive, it actually squeezes and shuts down those little capillaries. Well, this can easily happen, and this is an alveolar dead space, because now we have ventilation. We have gas moving to the alveoli, but there's no exchange with the bloodstream because we've closed off, we've impeded blood flow with that capillary. So alveolar dead space is the same thing. There's ventilation, no perfusion, but this is at the alveoli level. Physiologic dead space is an umbrella term that just combines these two. So overall, how much dead space do they have going on with both anatomic and alveolar combined? Well, how do we know what's normal for someone? When we're looking at this, this is the graph that I was just sort of trying to draw. What's normal for someone for anatomic dead space? We're going to do 1 ml per pound of ideal body weight. That's it. 1 ml per pound of ideal body weight is your normal anatomic dead space, right? So when we can actually calculate how much dead space someone has, or anatomical dead space someone has, and then we can calculate their physiologic dead space. When we subtract physiologic and anatomic, then we're going to be left with alveolar dead space, and then we can see if their alveolar dead space is increased or decreased after a procedure that we've done. Pretty interesting. So here is the graphic. I like this because it shows blood flow, and over here we have an alveoli that's well perfused, right? You see deoxygenated blue blood getting exchanged with the alveoli, then turns into red arterial blood. Beautiful, right? That is alveolar perfection. Then on the right, you see how there's no blood flow. It somehow got cut off, or maybe a patient hyperinflated and burst their capillary like we see with emphysema. They break a lot of the capillaries that surround their alveoli because of chronic hyperinflation. So it bursts those capillaries, so there's no blood flow. So they have an increase in alveolar dead space. There's no blood flow down there. Anatomic dead space is something you normally have, right? With your trachea, your main stem bronchi. There's just no gas exchange going on here. There's ventilation. There's gas moving up and down, but there's just no exchange of CO2 and O2. So anatomic dead space is normal, right? That's how much is in your conducting airways. The volume would be 1 ml per pound of ideal body weight, or 2.2 mLs per kilo of ideal body weight. Remember, those are the same, right? 1 ml per pound of ideal body weight, or 2.2 mLs per kilo of ideal body weight. So if I told you someone's ideal body weight was 160, then you would say that their anatomical dead space would be 160 mLs, right? So 1 ml per pound of ideal body weight is what you're looking at here. So the volume of gas that is wasted, so let's do this 1 ml, go here. The volume of gas that is wasted is the sense that it does not participate in CO2 and O2 exchange. So when we look at anatomic dead space, it's a mixture of both fresh and non-fresh gas. This is normal. This is going on in your body right now. Is it very significant? No. Will it affect you very much unless you have a condition? No. Right? So this is just something that naturally happens. It's okay, right? Our body's set up to compensate for that. When we look at tidal volume, right, that's the volume of gas what you're breathing right now, right? That's that roughly 6 mLs per kilo of ideal body weight, right? So tidal volume is important, but it doesn't really reflect how much gas is getting exchanged between the bloodstream and the alveoli, right? That external respiration. So only the gas that reaches the alveoli in that respiratory zone is involved with gas exchange. So if I want to look at how effective someone is at exchanging gas, I'm not going to look at their tidal volume. I'm actually going to look at what's called their alveolar tidal volume, right? So this is like volume alveolar. So alveolar tidal volume. So that's that VA here. So I don't have enough room. So alveolar tidal volume. So the alveolar tidal volume is tidal volume minus anatomical dead space. So I know that looks crazy, and if you're like, hey, that's too much math, let's do an example. If I told you someone's ideal body weight was 100 pounds and their tidal volume was 500 milliliters, all I'm going to do is take their tidal volume of 500 milliliters, right? So I'm going to take their tidal volume, and I want to subtract what their dead space is. And I told you their ideal body weight was 100 pounds, and we know it's 1 ml per pound. So all I'm going to do is subtract the dead space from their tidal volume, and that means the volume of gas that's being actually exchanged with the alveoli would be 400 mLs for this patient. Right? All I'm doing is simple subtraction. You're going to take their tidal volume minus their anatomical dead space. That's it. That's the whole thing. Okay? So if I ask you to tell me someone's their alveolar tidal volume, you're just going to take the regular tidal volume minus their dead space, which is 1 ml per pound. And that would be how much is actually getting exchanged with the bloodstream with CO2 and O2. Out of that 500 ml breath, 400 mLs of it's actually exchanging CO2 and O2. All right, that's great. Now I can look at one breath with that calculation. Now, that's great if I want to look at just one breath, but usually we want to look at, on average, how much gas is being exchanged with the bloodstream out of how much you're breathing. So all we're doing is now we're just adding the minute ventilation component to this, okay? So remember, minute ventilation is tidal volume times respiratory rate, okay? Minute ventilation, VE, or just big V, little e, this represents how much volume of gas we're just exchanging over the course of a minute. So this is something we can look at, right? But remember, minute ventilation, just like a regular tidal volume, will not reflect how much is actually getting exchanged with the bloodstream. So now we need to factor in dead space to this. Well, this is pretty simple. All we got to do, remember our example before where we took a 500 ml breath and we subtracted 100 milliliters of dead space, and we said their alveolar tidal volume was 400 mLs, right? This is something we just did. So now I'm going to take my alveolar tidal volume, which is what we got, right? And I'm going to multiply that times the respiratory rate. So let's say my respiratory rate was 10, right? What's 10 times 4, right? So when you're looking at this, the calculation now looks at how much they're exchanging over the course of a minute with their bloodstream instead of just one breath, right? A lot more reflective of how well or how effective their ventilation is overall. So this is something we can look at more specifically instead of be like, oh, they have a good tidal volume. Well, as we looked at before, if they're hypopneic, right, if they're breathing very shallow, that's not going to be very effective and they're going to have a lot of dead space. So why minute ventilation does not equal alveolar minute ventilation? So let's compare different rates, right? So patient A has a tidal volume of 150 mLs. And their respiratory rate's 40. They're breathing very rapid and shallow. Patient B is breathing 500 mLs and a rate of 12, and that's normal, okay? And then patient C is breathing in a full liter of gas, 1,000 mLs, and only a respiratory rate of 6. So they're breathing really deep, but very slow respiratory rate. So what's going to happen with this situation? So when we're looking at this, a rate of 40 times 150 is going to be a minute ventilation of 6. Okay, so we know the minute ventilation there. Our alveolar volume, remember we talked about being 1 ml per pound, and their tidal volume is alveolar volume. Their tidal volume is 150, so 150 minus their 150 of dead space, right? So we take their tidal volume minus their dead space. So their alveolar volume is 0. So how much gas exchange is this shallow, rapid breathing patient doing? No gas exchange, right? They're not exchanging CO2 and O2 with their bloodstream, right? It's very ineffective. So on these patients that are breathing rapid and shallow, if they keep doing this, if they do this for long enough, they're going to burn up and go into anaerobic. They're going to have high CO2 levels and low oxygen levels. So what's their alveolar minute ventilation? Well, that's their rate times their alveolar tidal volume, right? Their alveolar minute ventilation is their respiratory rate times their tidal volume. Well, their alveolar volume is 0. 0 times a respiratory rate of 40 is still going to be 0. So over the course of a minute, that patient isn't exchanging any CO2 and O2 with their bloodstream. That's very bad, right? Their oxygen levels are going to drop very quickly. Their CO2 levels in their bloodstream is going to rise pretty quickly. And the pH of the bloodstream is going to change pretty quickly on that patient. So rapid and shallow breathing is not very effective at ventilation. And we actually look at this. There's a rapid shallow breathing index. We look at people on life support. And if they're breathing really rapid and really shallow when we let them breathe on their own, we don't take them off usually, right? Because that's a sign their gas exchange is still very poor. What about patient B? Well, 12 times 5, right? What's our minute ventilation here, right? You can pause it, do the math, right? But when we do this, this is still going to be 6 liters. So we have the same minute ventilation as patient A. Now out of this one, How do we know what's their tidal volume? What's their alveolar tidal volume? Well, we take 500 mLs minus 150. So to do this equation, I want you to see what their alveolar tidal volume is. So what you're going to do here is you're going to take their tidal volume, which is 500, minus 150. When we do that, that means we're left with 350 mLs. So we actually have exchange of gas with the bloodstream. We have 350 mLs of CO2 and O2 actually exchanged with the patient's bloodstream. So over the course of a minute, I want you to now figure out what's this patient's alveolar minute ventilation. So you're going to take 350 times 12. When we do this, we're going to look at their alveolar minute ventilation, and this is in milliliters per minute, but this is going to be 4,200, if my math is right, 4,200 mLs per minute, which realistically we don't like such big numbers in the hospital, so we do like 4.2 liters. Right, that's the same thing. So on the exam, if you give me 4.2 liters, I will be very, very happy. If you give me 4,200 mLs, you're not wrong, but I won't count you wrong. But in that case, in first semester anyway, but usually if we get into the 1,000 range, we're going to go into the liters situation. All right, so they're exchanging a lot of gas with their bloodstream. Okay, when we're looking at patient C, what's their minute ventilation? Well, 1 times 6 is 6. So all three of these patients have the same minute ventilation. It's just what happens with their tidal volume. There's more dead space, so it changes. So when we're looking at their alveolar volume, what's 1,000 minus 150? When we're looking at this, you'll see that they have a lot more gas exchange. They're exchanging 850 mLs, right? That's much greater. Much, much greater. That means they can exchange a lot more CO2 and get a lot more oxygen into their bloodstream. So it's pretty significant. Now we're going to take that. If we want to figure out their alveolar minute ventilation, you'll be doing this on your worksheet, right? You'll see your worksheet in one of the day folders. So when you're doing this, you'll see that their tidal volume, well, you're just going to take their tidal volume times the respiratory rate, which would be 850 times 6, and then you'll see that their alveolar minute volume is actually 5,100 mLs per minute, or realistically in the hospital we would do liters, so it would be 5.1 liters per minute. So what's a normal alveolar minute ventilation? And you will need to know this. A normal alveolar minute ventilation is 4 liters per minute. Trust me, that will come up very handy later on. So what's the difference, big difference between these two? It's the rate and their tidal volume. So when you walk into a patient's room and they're breathing rapid and shallow, you know that they're not doing very well. They're not breathing very effectively. So that means you need to take action, right? The deeper and slower someone's breathing, the more effective their minute ventilation is, right? All three of them have the same minute ventilation. All have a different alveolar tidal volume and an alveolar minute ventilation. So which one is most effective? Why was that one the most effective? Right, that's a question for you to ask yourself, right? Hopefully you've received that information, right? This is a reflective moment for you. All right, alveolar dead space. This is when an alveoli is ventilated, right? We have a nice, beautiful alveoli. We're getting lots of gas that flows down into that respiratory zone here, but there's no perfusion, right? No blood flow. There's no blood flow that gets there, right? So this is usually a vascular problem. So these are ventilated alveoli, but there's no perfusion, right? This is usually a blood flow problem. So we have more ventilation, that's the V, than the perfusion, which is the Q. And the Q stands for perfusion, or QT, which would be the cardiac output, which is a way of looking at perfusion. So this is not effective gas exchange. So if we have someone that lost a lot of blood from a trauma, right? Like we go back to that guy that was in the car accident. They lost a lot of blood. So there was ventilation. We were able to exchange gas. We were able to get gas to go to the respiratory zone. But if there's no blood flowing past it, it's pointless, right? We need blood flow. And that's one of the reasons why you need to be both both a cardiovascular expert and a pulmonary expert, right? This is why we don't just do lungs. We are cardiovascular specialists as well, right? Big thing. So usually this is a vascular problem. What if they're vasoconstricted, right? What if they got hypoxic pulmonary vasoconstriction? So when you're hypoxic, you'll vasoconstrict in your lungs, right? And then you're not going to have near as much blood flow. So we have dead space ventilation going on. What about when we have a patient and we give them too big of a breath? Right, and then the lungs are so expanded, right, it's actually pinching off blood flow for gas exchange. We're causing that dead space issue, and believe it or not, this still happens out there. We have a bunch of people that still run a ventilator thinking, hey, the bigger the breath, the better, right? Because that's what the previous screen was talking about. Not necessarily. You can get a point where you actually cause more harm than good by giving them too big of a breath. That's why we need to make sure we're giving them the right volume of breath, right? Too big of a breath or too much expansion of their tissue can also cause dead space. It can also make it hard to exchange gas with your bloodstream, right? So this is where we're looking at overall dead space, right? Remember, dead space is, there's 3 of them all together. You have your anatomic dead space, which is 1 ml per pound, and that's just like your trachea, your bronchi, right? All this stuff up here. Your alveolar dead space, that's all this stuff down here, where you just don't have capillary perfusion there. There's gas flowing, but there's no perfusion down there. And then both of these together is called physiologic dead space. Is there a way I can figure out someone's physiologic dead space? Yeah, it's called the Bohr equation. I'm going to take their exhaled CO2 and their arterial CO2 over their arterial CO2. So I'm going to minus their exhaled PET end tidal. So I'm going to draw a gas. I'm going to draw blood from their artery. I'm going to look at how much CO2 is in their artery. Okay, so I'm going to do their PaCO2, so CO2 level from their artery, minus how much CO2 they exhale. So I have to put a little thing in front of their nose, their mouth, or their artificial airway, like an ET tube, and see how much CO2 is coming out, right? So I just subtract. I look at the gradient between what's in their bloodstream and then what they're exhaling, right? The bigger the gradient, the more dead space there is. And I just compare that gradient to the PaCO2, right? How much we were looking at before. And that's called your Bohr, B-O-H-R equation. And that looks at physiologic dead space. So I can actually know what their anatomic dead space is, 1 ml per pound of ideal body weight. And I know what their physiologic dead space is. So I know if I subtract anatomic from physiologic, what's left over is alveolar dead space. Pretty cool. So I can actually figure out, I can't directly measure it, but we can sort of estimate it. Right? So the sum of anatomic and alveolar dead space is physiologic. So anatomic and alveolar go in those spaces. Anatomic and alveolar dead space. So this is the total overall, how much gas does not participate in the bloodstream exchange. That's our physiologic dead space, right? This is something that we can calculate. It's not something that we usually measure or have currently, as recording this, a great way of measuring, but this is something we can look at together. We can calculate it. Scientifically speaking, a measurement's always going to be more valuable than a calculated value, but we can calculate it, and then we can sort of from there derive roughly what our alveolar dead space is and if it's getting better or getting worse. So as you're breathing, you're going to have difference in how you ventilate just based upon your pleural pressure, right? Your pressures will vary throughout your lung. When you're sitting upright, your apices have much more pleural pressure because of gravity, right? None of you are on the space station right now. So because of gravity, your lungs are being pulled down to the lower part of your thoracic cage, which means there's more of a gap between your visceral and parietal pleura in your apices than there is in your bases, right? The more of a gap there is between the visceral and the parietal pleura, the more suction or the more vacuumous pressure is created, right? Remember this? So therefore, your apices tend to stay open more than your bases because there's greater negative pressure. There's greater vacuum pressure up in your apices than your bases. Right? We also have, because of gravity, weight distribution of the lung of blood flow, right? Because the area lower than your heart, your bases and all that stuff, blood will easily flow down instead of being pumped up to your apices. You're going to have a lot more blood flowing to your bases of your lungs. So this means we're going to have a difference in ventilation perfusion in your apices, the middle parts of your lungs, and in the bases, right? We're a 3D object. At least all of you that I know are a 3D object, right? Because the negative pressure is greater in the apices of the lung, the alveoli maintain greater expansion. Therefore, they are less compliant. They are stiff. Remember the Hooke's law? For 1 unit of change, you'll get 1 unit of stretch. And until you reach that stretching point where it's about ready to burst, like a balloon that's about ready to pop and it doesn't move very much when you blow into it, that's what you're seeing here. It's at its expanded state. This is that Hooke's law application there, right? That means the lung compliance is lower in your apices, and your bases, which are less inflated, remember with gravity and weight and mass, all that hanging out down there, they're going to have increased compliance. That's because they're going to be at a more collapsed, more potential space down there. According to Hooke's law, they're going to move a lot more with the breath than the apices will. Isn't that crazy? So you can feel this right now. If you were to lay down flat, or even sit tall, and you put a hand over where your collarbones are, and then you put a hand over the base of your lungs, right, over the bottom part of your ribcage, feel which part expands more when you're breathing. They both don't move out equally, right? Your bases are going to move way more than your apices. Some of that has to do with your ribcage structure, but your movement overall has more potential with your bases than your apices because your lung compliance is lower in your apices, which makes it harder for gas to go up there, than in your bases where it's easier for gas to go in there. Isn't that crazy? Right, and this is just a picture to show that as we go from our apices, we're really open up here, right? Really open. We're almost Hooke's law to the point of breaking it. Down here we have a lot more potential space, right? We'll have a lot more potential expansion down there. It's be a lot more easy for gas to expand that lower part than the upper part because we're almost at the point of breaking up there. So what about patterns, okay? So if we have resistance or compliance changes, it will change how you breathe. So if a patient can only breathe with low tidal volumes, right, because they have a severe pneumonia, because they have pulmonary fibrosis, they're going to have to try to compensate by increasing their respiratory rate. But as we looked at before, because of dead space, because of alveolar minute ventilation, this is not going to be the most effective thing for them to do. They can only compensate for so long before they'll go into fatigue. So the more there's an increased resistance, the more the respiratory rate will increase, right? The more they're going to have to try to compensate this. So a patient will decrease their respiratory rate and increase tidal volume to maintain minute ventilation. So if we have airway resistance, so here let's do this whole thing where we draw the trachea, and then we'll draw the lungs. Okay, so if we have an increase in airway resistance, let's say it's a bad bronchospasm or something's happened to the trachea, right? So this patient's going to have a very long time constant. Their airway resistance is very high. So because their time constant's long, they're going to have to decrease their respiratory rate. So remember, minute ventilation is respiratory rate times tidal volume. So because their time constant is so long, they're going to have to decrease their respiratory rate. When they decrease their respiratory rate, the way to compensate is to increase their tidal volume to maintain that equilibrium of minute ventilation. Okay, so that's what we're looking at here. So with decreased compliance, they're going to have to do the opposite. They're going to have a shallow tidal volume, right? So this is with this situation, airway resistance. Down here, respiratory rate times tidal volume. And this is your patient that's breathing shallow, so their tidal volumes are small. So here we have our trachea and then our lungs. Okay, so this patient, their lungs are restricted. And I'm just going to box them in there. They can't expand, right? So because their tidal volumes are decreased, they're going to have to compensate by breathing faster. This is the compliance tidal volume relationship, right? And your book actually talks about this a little bit, and so does your workbook. So when you're going over that stuff, this should start to make a little bit of sense. So the lower the compliance, the faster they'll breathe. The higher their airway resistance, the slower they'll breathe. Hopefully you'll see that. All right, so to minimize, the brain controls the respiratory changes by minimizing the work of breathing and their oxygen demand. So this is a graph that I took from the book. I don't know if it's in the current edition or not. So this is just showing the same thing that I just drew on the other slide, right? As your compliance decreases, right? As your compliance decreases, you're going to have to increase your respiratory rate. So down here on the x-axis is your respiratory rate, right? That's the fancy word ventilatory frequency. And up here on the vertical axis is your tidal volume, so how deep you're breathing. So as your respiratory rate increases, odds are it's because your compliance is decreased. In other words, the smaller the tidal volume, the faster the rate has to be. The smaller the tidal volume, the faster the rate. The higher the tidal volume, the slower the rate. Right? That's all what we're looking at with that elastance-resistance relationship. All right, so now we get into definitions. We're almost done here. The complete absence of spontaneous breathing is called apnea. A-P-N-E-A. Apnea, right? Apnea, right? Without breath, right? Death will occur usually within minutes. So let's just go back to yellow. All right, apnea. So this is when we'll talk about this later on when we get to disease class about sleep apnea and central apnea and all this other stuff. Normal spontaneous breathing called eupnea, and this is all from your packet from the very first week of class. E-U-P-N-E-A, eupnea, so normal. So there's a type of respiration where it's short episodes of rapid deep breathing and then nothing, right? And then same thing, rapid deep breathing and then nothing, right? So rapid uniformly deep by 10 to 30 seconds apnea. This can happen in meningitis, and this is called biots. B-I-O-T-S. Biots. And so this can happen in brain disorders and neurodysfunction. This is where it was first noted, but we've also seen this in other types of patients. I remember having a patient in critical care, and they were on a ventilator, and I noticed that their spontaneous effort was biots, and the pharmacist was standing next to me, and I'm like, yeah, it's biots breathing, and she didn't know what that was, and she looked it up on her pharmacy thing, and I guess they had put the patient on a medicine that could then cause that type of pattern. So it was pretty interesting to actually bring that up and understand why the patient had that pattern, because that could be a very bad sign, right? Meningitis, not a great thing to have. And so it was a good thing to bring up, and it meant for a good discussion amongst the professionals at that bedside of that patient. So it was pretty cool. More definitions. Increased depth of breathing with or without frequency changes. So this is just taking a big breath. This would be a hyperpnea, H-Y-P-E-R-P-N-E-A, hyperpnea. So this is just a big breath. Increased depth of breathing without frequency change. So if you just take a big breath, like a sigh breath, right, or a yawn or something like that, that's a hyperpnic breath, right? Hyper, right, big breath. Hyperventilation, big difference here, is an increase in ventilation that causes their CO2 levels to drop. Once again, this one up here does not cause CO2 levels to drop. So if I'm asking you on a future assessment document which type of breathing pattern causes their CO2 levels to drop in one way or another, I'm looking for hyperventilation. That's where I'm actually exchanging and getting rid of a lot of CO2. So hyperventilation is breathing fast and getting rid of CO2. So let me ask you this. If my tidal volume is only 150, my dead space is 150, we go back to that patient A from before, are they hyperventilating because they're breathing 40 times a minute? Are they hyperventilating? Well, remember their alveolar minute ventilation was 0. Their alveolar tidal volume was 0. So can you be breathing fast and not be hyperventilating? I would submit to you absolutely. So hyperventilation means that we have a CO2 level that's decreased from their bloodstream. So if I'm breathing 40 times a minute and I have a low CO2 level from a blood gas, from the test we draw from an artery, then they're hyperventilating. But just because someone's breathing fast does not mean they're hyperventilating, right? That's what we talked about, alveolar minute ventilation and alveolar tidal volume being a factor there. Right? So the next bullet point, a rapid rate of breathing may or may not result in hyperventilation. We just covered this, would be tachypnea. Tachypnea, tachypnea. So if someone's breathing fast, you can say they're tachypnic. Let's say they're breathing at a rate of 40. Hey, they're tachypnic because the normal rate for an adult is 12 to 20. So they're tachypnic, but until I get their CO2 levels, I cannot say scientifically they're hyperventilating. Does that make sense? All right, last one here I think is Cheyne-Stokes. Cheyne-Stokes is where I like to call this one the Bob Ross. This is where they'll have 10 to 30 seconds of apnea where there's no breathing, and then they're going to have a gradual increase in frequency and depth of breathing, and then back down again. And then apnea again for 10 to 30 seconds. So it's like the mountains from the whole Bob Ross Joy of Painting thing, right? So this one, they're going to have that increase in tidal volume and frequency of breathing, gradual decrease, and then apneic. And this was noted most commonly with cerebral disorders or neurological disorders, brain swelling, things like that. You can see these type of things. It's also something that can be noted during REM sleep. And even little babies in the NICU, if you get to walk through the NICUs one day down the road, you can actually see in the respiratory pattern, some of them will go into this Cheyne-Stokes breathing. And this can be something that happens normally with REM sleep as well. All right, Kussmaul's. Kussmaul's mean we're going to breathe really fast and really deep. And where we typically see a Kussmaul's is in a diabetic ketoacidosis, also known as a DKA, right? So what's happened? They're in an acidosis. So CO2 is a carbonic acid, right? The CO2 in your bloodstream is a carbonic acid. So if your body is acidic, what will it do to reach equilibrium? Are you going to breathe fast to get rid of CO2? Absolutely. So they're going to breathe fast and deep. So if you're looking at this breathing pattern, it's right? They're breathing really fast, really deep, right? And the idea here is to get rid of as much CO2 as possible to help reach their pH back to an equilibrium that's not nearly acidic. So DKA, rapid and deep, rapid and deep, rapid and deep, right? That's called Kussmaul's respirations. Orthopnea is a condition when the individual is able to breathe most comfortably in the upright position. So if you lay them down flat on a bed, they're going to feel like they're suffocating. But if you sit them up in a lazy boy chair or sit them at Fowler's position or semi-Fowler's position, they're going to breathe better. That's called orthopnea, right? So when they're orthostatic, when they're laying flat, they're not going to be able to breathe very well. And this is more common with patients that have congestive heart failure, right? Where that blood will back up into the lungs like we talked about with the first chapter. So they're more likely to have orthopnea. There's an inverse where people will breathe better laying flat called platypnea as well. Not something I will ask here, but that's the inverse of orthopnea. All right, last one down here. Difficulty in breathing. This is a symptom. This is a subjective. This is the only one of these that is subjective. They must be aware that this is going on. This is called dyspnea. D-Y-S-P-N-E-A. Dyspnea, right? This is where they feel like they can't breathe. So if you walk into a patient's room, introduce yourself, and they say, I feel like I can't breathe, then you can state that that patient had dyspnea. But if they never state that they have trouble breathing, it's not something you can chart. This is something they feel, they're aware that they're having a hard time breathing. So if on a future assessment document I say which one of these is where a patient is feels this way, or the only one that's subjective condition, if you see that word subjective, think dyspnea, right? This is where the patient says, I feel like I can't breathe,